Good morning, everyone. My name is Jamarius Coley. I am an order manager for advanced therapy products for Siemens Medical. I'm based out of Malvern, Pennsylvania. It's my pleasure today to introduce you to our speaker for the COVID-19 and Stroke Risk Seminar. As an expert in neurology with more than 20 years of experience, Dr. Adam S. Arthur is an expert on brain aneurysms, a blood vessel condition that can lead to hemorrhagic stroke. He holds a master's degree in public health, focusing on improving methodologies used to administer clinical trials. He currently serves as the director for cerebrovascular and endovascular neurosurgery at the Sings Murphy Clinic and at the University of Tennessee Department of Neurosurgery. Today, Dr. Arthur will be leading our session on COVID-19 and stroke risk. Without further ado, I introduce to you Dr. Adam S. Arthur. Take it away, Dr. Arthur.
Thanks, Jamarius. It's a pleasure to be here. I'm gonna share my screen here, just 1 minute. I'm coming to you from Memphis, Tennessee, in between cases, so I apologize for my garb, but I'm happy to be here. I'm going to talk for just a minute about neurosurgery. Neurosurgeons love to talk about themselves. They're known as very arrogant people, so I have to do that. And then I'm going to talk about stroke, about COVID. I'm going to go through some scientific data, the early data we have pertaining particularly to COVID and stroke in New York and nationally. And then I'll be happy to answer any questions that might come up. So I am a neurosurgeon. And what I do is I operate on the brain, both through an opening in the skull or sometimes through a small catheter that we place through the wrist. You have phenomenal neurosurgeons in New York. Howard Rena at NYU, Jay Mako runs the group at Mount Sinai. I'm going to show some of their work. But maybe the most famous neurosurgeon in New York is Dr. Stephen V. Strange, the master of the mystic arts, who's a Marvel comic book hero. You know, I can't really compete with him. I'm not a wizard. I will say that Dr. Strange is on Twitter and he follows me. So that may be one of the high points in my career. And, you know, I may have one leg up on him because he's only got about 300 followers. And, you know, I'm not exactly big on Twitter, but I've got, you know, more than 2,000. So I got that going for me. I'm in Memphis, Tennessee. I'm not from here. I came here because I want to help stroke patients. And if somebody were to walk into my office and drop a nuclear bomb, you might see an area where people were horribly affected and then a larger area where people were affected to a lesser extent. Well, that's what's happening on a daily basis. These are the Centers for Disease Control data on hospitalization rates for stroke patients. And what you can see is we've got this, sometimes they call it the stroke belt that runs through the middle of our country. It is the disease most likely to disable American, third or fourth leading cause of death. And then unfortunately, just like hospitalization, death looks very similar. Stroke is a time-sensitive emergency. We've learned that when there's a large blockage of an artery in the brain, people are losing weeks of their lives by the minute. They're losing 2 million neurons a minute. And so I spend a lot of time, not just doing surgery, but doing everything I can to try and make sure that we don't lose that time and that patients get in on time.
Quiet, please. Wait a sec. I'll take one. Oh yeah. All right. All good. Take care. Way to go. Nice. Bring it on. Gotcha. I'm here for you. Oh no. Please, please, please. I'm waiting. Interesting. Not buying it. Not fair. That's it. This conversation is over. Oh, brother.
Body language can tell you all sorts of things.
I'm having a stroke. I'm having a stroke.
Know the sudden signs. Learn fast. F. Face drooping. A. Arm weakness. S. Speech difficulty. T. Time to call 911 immediately. The sooner they get to the hospital, the sooner they'll get treatment, and that can make a remarkable difference in their recovery. Learn the body language, the sudden signs, and spot a stroke fast.
I've been showing that video for years and it still gives me chills. One of the things about stroke that's so hard is, unlike almost any of the other diseases we face, patients often are not screaming and asking for help, and you have to watch for it. And that, I think, plays a large role in what we're seeing in the linkage between COVID and stroke. So we in Memphis have fought to do everything we can to get patients in quickly. We even have this stroke mobile. We've got bigger streets and less traffic than you deal with in New York. And so CAT scanners, CT scanners, are an important part of diagnosing a patient with a blockage in a vessel. And this is a way where we can actually bring a CAT scanner with Siemens help directly to patients. We did the first scan on a patient that we pulled off an airliner for a plane that dropped down in Memphis with a stroke patient on a runway. And we're going to do everything we can to improve what we can do for stroke patients. But I want to show you a little bit about what we do when someone has a large vessel occlusion stroke. There's different kinds. So here's a specific example, a woman who agreed to allow me to help show her case. She suddenly developed slurred speech and inability to move her left arm and leg well. And with large blockages in blood vessels in the brain, we give this clot busting drug, alteplase or TPA, but it doesn't often work for large vessels. It's better for small vessels. So it didn't solve her problem. These are the images that we were able to receive from our stroke mobile. And if you look on that upper left side, you can see the little twigs, the arteries, and there's one that just comes to a halt right in the middle there. And that's the problem. That's a clot. So we brought her right in and did x-rays. This is angiography. And again, if you look now on let's see, the left side of the screen, or I guess the right side, sorry, sides are important in my business too. You can still see that blocked vessel on the x-ray. So here's a real-time video showing how we deal with that. We went through a little pinhole with a catheter in her wrist as fast as we could. And this is us pushing a wire through the twists and turns to the arteries in the brain to get up to that blockage. And here you can see the wire getting to that blockage point, and over the wire, we're putting a catheter going through the clot into arteries that are not flowing, that are beyond that blockage. We look and we make sure that we're into the artery. We are, the flow is slow. And so now what we're doing is opening a stent, just like the stents we use to open arteries in the heart. It's hard to see there, but that will mash the clot, and then we vacuum and pull the stent back. And when we do that, now all of a sudden there's this area of her brain which controls her ability to speak and her ability to move her arm and a leg that was closed, that's now open. And so if we get to people quickly enough, we can reverse this kind of stroke. We can give them back their function and their life.
I feel good. I was too weak to walk any further.
Okay. Does this arm work now?
Yes, it was.
Give me a good squeeze. Okay. And then let's see your foot here. Can you kick the doctor? Can you kick your foot up? All right. Pretty good. All right. So how you feel this morning?
I feel great.
We don't always get that kind of result. Obviously, I'm showing you a good result, but to give this woman back her ability to speak, which if it had gone minutes or hours later, she might have lost permanently, and her ability to move her right side is really a big deal. So let's talk about COVID for a minute before I connect the two. There's a lot of speakers here talking about COVID, so I'm not going to get into it in detail, but essentially it's this little spiky virus that you've seen before that attaches to a specific protein called the ACE2 receptor. It gets into our lungs. We thought at first that it was coming on surfaces and so forth, but really what it is it's people talking and laughing, and it gets into your nose and your lungs. And we don't have it all figured out yet. Some people get a lot sicker than others, and it doesn't always make sense. But what we are seeing is that people who have stroke risk factors like high blood pressure, diabetes, heart disease, kidney failure, they have a much higher chance of getting sick or dying from this. And these are things that are very prevalent in the population that I serve. Memphis is one of the only large cities in the United States that's majority African American. And these diseases are things that affect African Americans at a disproportionate level for a variety of different reasons. But a lot of it has to do with the big three: diet, exercise, and sleep. And you know, here in Memphis, we fight to avoid food deserts. We fight to make sure that people have access to good foods. These are these are some recent data. The gray bars, which you see underneath there, are the population by race breakdown. And on the left, you've got cases. On the right, in blue, you've got deaths. And what you can see is that our people of color are getting COVID at a rate by population that's higher than whites. And then unfortunately, deaths are also significantly higher than whites. And this pandemic just seems to be worse for people who already have it worse in terms of health issues. So in New York, which got hit incredibly hard, we saw increases in both the number and severity of strokes, but we also unfortunately saw fewer patients getting to the hospital in time. So I mentioned Dr. Mako and the Mount Sinai group. They're a phenomenal group, just fantastic there in New York. And so these blue slides are their work. I don't want to take credit for their work, but they were good enough to share it with me, looking at what they saw in the worst outbreak. And I'm going to go over some scientific stuff here, but basically what they saw was that there was this increase in stroke, and the increase seemed to be related to patients who had COVID bad. And some of them didn't have some of these systemic diseases. There were some of them who had been pretty healthy previously, but when they got bad stroke, they seemed to have clots. We don't have this sorted out. It may be that your immune system takes such a hit and gets so revved up that it's sepsis, or it may be related to this ACE2 protein, which COVID binds to, which is also in our blood vessels, causing clotting in blood vessels, which I think is quite possibly part of this. But what we saw in New York during this worst time was two things. One, there was this huge increase in stroke patients. Two, we weren't getting them fast enough. In fact, I think one of the things that I'm going to show from all cities in the US is that there was this huge increase in deaths of unknown cause. So the early evidence does seem to indicate that COVID picks on people of color more, and that it increases your chance of having a stroke. But then unfortunately, it also decreases the chances that people are getting to the hospital on time, which is a big, big deal for these large strokes, because we want to help the people that we can help. So I'm going to go over some of that evidence briefly. This is the New England Journal of Medicine. What they looked at was a computer algorithm that's used in a lot of different centers throughout the US. This is the number of hospitals using this computer algorithm. And what you see is that when we had our national emergency orders, and when people started to get worried about COVID, sometimes even before the pandemic had gotten bad in communities, we saw this dramatic decrease in patients getting to the hospital for stroke. There's another source, another computer algorithm, same thing. As COVID deaths went up, even before the deaths go up, we see this drop in stroke patients getting to us, which is very troubling. So it's like a pincer movement. On the one hand, it's making people worse and giving them a higher chance of having a stroke. On the other hand, it's giving us a harder time of getting the patients quickly enough. And we're seeing that across the board. We're seeing that in all of these different centers. You can see all the different cities there that we studied. And what we saw was this decrease in the number of strokes reported that came along with public sentiment and the stay-at-home orders. There was no difference in the severity between during the pandemic and out of the pandemic in this data set, but the mean time from presentation, from when they first had that paralysis or difficulty speaking to when they could get to us, was dramatically increased. And as I said, that means that these patients are much more likely to die or have permanent disability. So deaths of all cause went up whenever COVID-19 hit in every geography, in every city. The number of stroke patients presenting to hospitals went down at the same time, and the phenomenon seems to actually lead the disease. So why is this happening? Well, I don't think it's reduction in risk factors. I don't think during a pandemic, when we're fearing for our lives, that there's any decrease in stress or improvement in our diet or in the use of drugs or alcohol. I do think it's social isolation and fear of COVID exposure. I think if you're having symptoms of a stroke, you're in that crisis of confidence. Should I do something about this? Should I take an aspirin, lie down, call EMS? That fear probably led to some people not going to emergency rooms. And then the other thing is social distancing has been an important way to fight the disease, but it's a double-edged sword. We're dependent on each other. We're dependent on this community. And if we're not checking on people, not everybody's got family right there with them. If we're not checking on people, I'm worried that some people are having a stroke and we're not getting to them quickly enough. I think that's probably a big part of this, in addition to COVID causing an increase in stroke. So I'm going to finish a little ahead of time because I wanted to make sure that there was time to answer questions. And I see there's 2 questions. I'm going to hit them just as soon as I finish here. COVID-19 is a disease that is worse for people who already are facing challenges. It disproportionately affects people of color. It disproportionately affects people who have high blood pressure, diabetes, and heart disease. I think there's probably an increase in strokes in patients who have severe COVID. It may be related to clotting in the arteries. We don't have that fully proven, but the evidence seems to point to that. But paradoxically, we are also seeing fewer of these severe stroke patients, fewer percentage, coming to the hospital as we get into this pandemic. And this has led to a very sad phenomenon for a lot of people. So what can we do? Well, we depend on each other. And as I said, sometimes I ask people to imagine an emergency room and you've got 4 rooms in front of you and you're the nurse and you've got to figure out who to take care of. Let's say in room 1, there's a woman having a baby. In room 2, there's somebody with severe psychiatric problems who hasn't gotten their medicine. So they're screaming and yelling. Room 3, it's somebody who's got severe reflux and they're worried they're having a heart attack. Room 4 is a woman who's having a stroke. All 3 of those first patients are probably going to be okay if you give them some time before you treat them. But that 4th patient who's quiet, who's not yelling, but who simply has that drooping face, she is dying. She is losing her ability to be there for her community, for her family, to do the things she wants to do. And so we all have got to be focused on that. And when we see these symptoms, we've got to get patients the care they need. That is the deadly and horrible, evil thing about stroke, is that it can be sneaky. And most Americans rate being disabled and not being able to do the things that are important to us as their biggest fear. But many Americans can't even name one symptom of stroke. So what we can do is to check on each other. What we can do is to stay connected as a community. What we can do is to know what those signs are. And then, of course, we're going to get out of this pandemic by getting everybody vaccinated and probably keeping up that vaccination. So that's a very important thing too. I'm happy to be vaccinated, happy to be here in between cases, taking care of patients and able to speak to you. Thank you for the opportunity very much. Let me look and see what some of these questions that have come up are. So are younger COVID-19 patients more vulnerable to strokes? Well, it depends on how you parse that question. That's a very smart question. Younger patients who have COVID are definitely more vulnerable to strokes than patients who do not have COVID. But younger patients with COVID are not more vulnerable than older patients. So patients who have heart disease, diabetes, renal failure still probably are more vulnerable. So that's the two ways to answer your question. If you suspect someone is having a stroke and you are an hour to 15 minutes away from an excellent hospital, but close to one that's mediocre to poor, should you get the person to the superior hospital or go to the inferior one? Boy, these are really good questions. So this is something I am very much engaged in. I am a stroke surgeon and we're not everywhere. And I really think that if somebody has severe signs of stroke, they need to go to a center that is ready to do that surgery rather than to go to a smaller place and then have to get transferred to the other place. But this is something, you're asking about something that is cutting edge. We are not there yet. We've done much more for trauma patients. We know that in a car accident, there's a golden hour to get the patient stabilized. So what you're talking about is bypass, and we'll take that trauma patient and bypass and go right to a trauma center. We're working to do better than that on stroke. So I would say that if you know that somebody is showing signs of a severe stroke and it doesn't cost you a lot of extra time, it is better to go to what I would call a level 1 stroke center where they have the ability to do the procedure, not just give the clot busting drug, but go in and remove the clot. But as you might imagine, where the rubber hits the road there, it gets a little difficult. So your local situation about whether it's an hour and whether 15 minutes, that gets to be a little difficult, but you ask a really good question. Next question is, how are clinicians treating COVID-19 patients who have strokes or clotting issues? Another fantastic question. Again, some of the New York hospitals have really led this. We have worked on whether we should be giving blood thinners, clot busting drugs, whether we should do procedures. What we know is keeping people from getting into this horrible storm using a variety of different medications, steroids, seems to be very helpful. If they are actually having a stroke, I think there's probably a combination of the procedure to remove the clot and medications that is the best thing, but it is complex. These patients have multiple different issues, and balancing the different issues and trying to figure out what to do can be very challenging. Does it lower your risk of stroke if you are iron deficient? That's another interesting question. Severe anemia or iron deficiency actually increases your risk of stroke because it lowers your body's ability to carry oxygen to the brain. But a low level of iron deficiency is probably not terrible. I don't think iron deficiency does in fact lower your risk of stroke demonstrably, but I have to admit that's not something I'm expert on. What signs should I be looking for as an allergic reaction to COVID-19? 92-year-old father can't swallow shortly having a second vax shot. Great question. I know a doctor who had that happen. She's a surgeon who's an expert in the airway, and she had swelling in her airway after the second vaccine shot, like your 92-year-old father, and was concerned. That can be an emergency. So you're right. What you look for is swelling, any kind of difficulty with swallowing. That's why when people get the vaccine, it's best policy for us to watch them for at least 15 minutes after the vaccination. Those allergic reactions are rare, and I really hope, I do a lot of listening to patients about how they feel about the vaccine. There's a lot of feelings there. I would like for as many people as possible to get vaccinated and not to be scared by this, but you've identified a real issue. Allergic reactions like swelling, hives, difficulty swallowing are important things to watch after any kind of shot or drug is administered. Great question. Is there anything we can do while waiting for an ambulance? Man. So if somebody has signs and symptoms of a stroke, their face is drooping, they can't keep both arms up symmetrically, one side of their body isn't moving well, the most important thing is to call for that ambulance as soon as possible. I think while waiting, it's important not to panic. It's important to make sure the patient's airway and blood pressure are reasonable. And I think those are the main things. Because different strokes are different things. Stroke can mean either blockage of a vessel or bleeding. It's hard to do much more before you know what you're dealing with. So that's why that CT scan is so important. For instance, if they have bleeding, you wouldn't want to give them aspirin or even a light blood thinner because you want your body to be able to stop that bleeding. But if they have a blockage of a vessel, well, then maybe aspirin or even stronger medication is the right thing to do. So basically, while waiting for the ambulance, I think somebody like you who's thinking ahead and being a leader is the right person to keep everyone calm, make sure the patient knows they're being taken care of, and make sure that basic things like their breathing is okay. Say more, right? Diet, exercise, and sleep to prevent strokes. Well, I call those the big three because speaking myself, I know I'm better when I'm eating good foods, a plant-based diet, staying away from fat and heavy meats, which, in my area of the country are prevalent. And then sleep, as a younger man, I was proud of the fact that I could work and get away with little sleep. And I can function, I can operate, I can teach on no sleep or little sleep. But I am a much better person. I'm a healthier person, honestly, if I get a good night's sleep. So when your body is fighting COVID infection or hypertension or any of the other things we fight, trying to maintain a regimen where you're getting good sleep, we call it sleep hygiene, where you go to sleep the same time every night, you wake up in the morning, you get enough sleep, you avoid lights in your eyes. Those phones are in front of us all the time now. And if you can't sleep, you're going to shine a light in your eye. That's not good for sleep. Getting exercise every day if you can. These things are incredibly important and they absolutely improve your health. As I said, my lane is operating on brains, but I need to listen to my patients. I need to give them advice, and then I need to do the absolute best to serve them and take care of them. And part of that is acknowledging some of these things that we face. For people of color, things like access to good food in my community are not well taken care of. And so outreach and trying to improve the general ability for people to take care of themselves is incredibly important. You know, I said my lane. I want to be clear. I think if you are a person of color, you're dealing with challenges in terms of racism and structural problems all the time. And what I meant to say was not that that's not my problem. I think to try and take care of the people I want to take care of, and the majority of my patients are people of color, I need to recognize that struggle never stops. It's exhausting, and I need to constantly be looking to support Black businesses and to help people with finding their own healthy choices, and listen about, for instance, why they might be reluctant to get a vaccine and trying to help them with that. So I wanted to be clear on that. Are people with pulmonary conditions like asthma, COPD, vulnerable to stroke or severe side effects from COVID-19? Yes. COVID-19 affects your respiratory system, your ability to breathe. And so people with pulmonary conditions are at an increased risk of stroke. And it has not popped up as one of the top things. Like I said, you know, diabetes, heart disease, kidney disease, but it is on the list of people who are more vulnerable to stroke and side effects from COVID-19. So the answer to your question is yes. If you had a stroke, can it happen again? Yeah. You know, sometimes patients ask me, you know, doctor, is there any chance this happens again? And I say, yeah, again, neurosurgeons are arrogant people. They think they know everything, but I'm not God, and I can't give you a guarantee or a warranty. And there are risk factors like blockage in the arteries that sometimes make people vulnerable to multiple strokes. So unfortunately, that answer is yes. But if you have a stroke, we want to look at that. Hopefully, an expert set of nurses, doctors, healthcare providers can help you to analyze what we can do to lower the chance of it happening again. Should I be concerned if after the first vaccine I have swollen lymph nodes? Yeah, I don't think you should be panicked, but I think you should be concerned. I think that's something that you should talk to your healthcare providers about. I have not heard about swollen lymph nodes being a typical concern after the first vaccine. And again, as a brain surgeon, I'm good at one little area. I don't know everything about health, but I think that is something I would bring to the attention of your healthcare help. Should patients who have had a stroke repeat a head CTA scan if it's been less than a year since they had a stroke? How do you monitor stroke patients after they had a stroke? Such great questions. You guys only gave me 30 minutes. I feel like I should spend my whole day with you guys. So it depends on the kind of stroke they've had. How do you monitor patients after they've had a stroke? It's a great question, but we have to look at what caused that stroke. For instance, in older patients, particularly, heart arrhythmia is a frequently missed cause of stroke, because if your heart isn't pumping in a coordinated way, clot can form there, and that can then go flying up into the brain. So we need to look to make sure if there's a heart arrhythmia, and if it is, can we fix that rhythm, or do they need to be on blood thinners to fight the ability of clots to get going into the brain? So monitoring for somebody who has atrial fibrillation or heart disease causing a stroke would be different than monitoring for somebody who has a blockage in their neck artery that causes a stroke. So I can't say that every patient who's had a stroke should have a head CTA scan. It's really going to depend on what kind of stroke they had and what we know about that. If the person who is COVID positive is having a heart attack, is it safe for a COVID negative person to give CPR if needed? Wow, another great question. Thank you, Barbara. So modern CPR involves a lot of maintaining a rhythm, and safe is one of those hard words. You know, we like to judge, we like to put things in categories, but it's a gray area. If somebody's COVID positive and you're COVID negative, you ought to be doing everything to avoid what we call aerosolization or drops coming out of that person's airway and getting, onto your mucous membranes. So I definitely would want to do everything we can to keep somebody alive who's having a heart attack, but I cannot tell you that there's no risk in CPR. I think the risk is minimal if you keep that patient masked and you have a mask on yourself and you're doing chest compressions, but it's not zero. This is just, the world we live in and the kind of compromises we have to deal with. Never taken any flu shot, in my 70s and healthy and eat healthy. I'm not keen on foreign substances going into my body. Not sure about taking the vaccine. What are your thoughts for a healthy 70-plus-year-old? Great question. You sound like a lot of patients that I've talked to. Again, I'm a doctor. I want to help you. I want to support you. You get to make the decisions. I'm not here to be, your boss. I think weighing the risks versus the benefits, allowing that vaccine to let your immune system see this protein, this evil spike protein, and get accustomed to it so that if you are exposed to COVID, your immune system is better equipped to fight it, is really a good idea for a healthy 70-plus-year-old. I was excited when my parents could get the vaccine. So my advice is, yes, you should get the vaccine. It sounds like you're very healthy. And if you got COVID, that would lower your risk of having a severe case. But I know marathon runners who've ended up, on a ventilator in the hospital. And it's not just about dying. Some of these people are sick and it takes a big chunk out of them and sometimes makes them sick for the rest of their lives. So I absolutely positively think it is the best idea for you to go ahead and get vaccinated. But I understand how you feel about it. And I understand your concerns. Are there predictive tests for strokes? The answer to that is yes. So as we get older, we do need to look at things like heart arrhythmia, ultrasound to look for blockages in the neck, things like that. There are things that you can do to control risk factors to lower the risk of stroke. But that doesn't mean that you can always avoid it. Sometimes I'll see somebody who's relatively young or relatively healthy and they've had a devastating or horrible stroke. And the majority of time, the person who's closest to them, their partner, their spouse, has this sense of grief and a sense of guilt because they want to know what could have been done. And they feel like I let them down because they had a stroke. And I often have to sit with that person and say, look, this is not your fault. There was no way of predicting this. So yes, there are some predictive tests, but it's a long way from 100%. And so sometimes stroke just strikes like a lightning out of the blue. It just is what it is. Should someone that had a stroke be taking aspirin or prescription medication to help prevent another stroke? I think the answer to that is a qualified yes. Aspirin is fairly gentle. It's been around a long time, and there are a lot of good effects to it. So if they've had a blood vessel blockage stroke, if there's not a risk to them taking aspirin, for instance, they don't have bad bleeding in their stomach, ulcers, then I think it probably is a good idea. But again, it's going to depend on that specific case. And I really believe in individualizing medicine. It's not a recipe. We need to really listen and look at that individual patient, try and figure out what's going on for them to be able to answer that question. So it's a qualified yes. Most people who've had a stroke would benefit from some aspirin. But I think that's something you should talk with your healthcare provider about specifically in your case. Am I familiar with patients experiencing frozen shoulder after having an ischemic stroke? If so, how long does it typically last for, and what is your recommendation on how to treat it? Whew. I know of people who have paralysis or weakness, and then that affects the joints and they end up with frozen shoulder. I'm not sure if that's exactly what you're talking about, if you're talking about something else. I don't feel like I'm qualified to tell you exactly how long it lasts and how it's treated. Because again, my lane, my real expertise is in operating on the brain, going and cutting open the skull and going in there, or going through a catheter and to go in there. And so I do think that that's something that, for instance, a rehab and physical medicine doctor would be probably better to diagnose and treat than I would. So I'd love to be able to help you and answer that question better. And I'm sorry, I'm giving you a weak answer. I don't know everything. Whew. Boy, you guys really brought the questions, and I think I'm right about out of time. So thank you so much for this opportunity to speak to you. And I think I should probably turn this over to the next speaker. You're welcome. You're welcome to all of you. I appreciate the chance to talk to you. Like I said, I got family in New York. I love New York. God bless you. Vish or Jamarius, do you know how we move forward here? It's right at 11.
Thanks, Dr. Adams. I think you can just disconnect and we'll just move on to the next speaker. Thank you so much.
It's nice to meet you. Maybe we'll meet in person someday. And again, thank you for the opportunity. I appreciate it.
Likewise, enjoy the rest of your day.
You too.